Hi, I'm Dr. Robert Kaufmann, and we're about to go beyond the terminus. Retreatment choices are not often cut and dried. When faced with a failing endodontic case or persistent post-op endodontic symptoms, we must consider many factors. Let's discuss what influences our decision to retreat either conventionally or surgically. One of the main factors that we have to consider is the preoperative condition of the tooth and restoration. Is the restoration to be replaced? If so, disassembly frequently offers better access to the canal system because of removal of potential access obstructions and shortening of the working length. Close examination of restorations and crown margins is an important part of the retreatment strategy. There's no advantage in conventionally retreating a failing endodontic case only to worry about choroidal leakage or suboptimal crown margin fit. In the case of retreatment, these issues must be discussed with both the patient and the dentist prior to initiation of treatment. It's unfair to patients to expect to salvage the existing restoration only to find the costs of rehabilitation of the tooth have doubled because of the need for a new restoration after the endo has been retreated. Secondly, what are the disassembly costs? If we're considering disassembly, how will this affect the overall treatment plan? Removal of post frequently requires removal of some dentin. Similarly, there is no advantage to disassembling a tooth to attempt to access a broken file, only to have perforated, stripped, or weakened the tooth to the point where the tooth no longer justifies re-restoration. Have we really helped the patient in that case? How have we made the situation better for them? Perhaps leaving the adequate restoration in place and treating the problem surgically may have been a better alternative. Thirdly, conventionally retreat before surgery or not? The general rule is that most endodontists prefer to do surgical procedures up against their own gutta percha and treated canals. This ensures that the canal has been cleaned as well as possible by them and that we are simply not placing a retrofilling over a less than optimally treated canal system. There's no point in attempting to put a seal on a trash can if the trash isn't removed. Sometimes this is not possible, such as in the case of anterior teeth restored with post and core crowns. If the aesthetics and crown fit are good, it may be more expedient to do surgery rather than risk further loss of tooth structure through disassembly and re-restoration. Calcified canals are another variant, and by that I mean canals that are not visible on CBCT imaging or where ledging of the case by previous treatment makes attempts to retreat the case very difficult. Every case is unique, and it must be judged on its own merits in consultation with the restoring dentist. Fourthly, anatomic location. Goes without saying that surgical treatment in the mandible is frequently more challenging than that in the maxilla. The further back we get in the mouth, the more difficult the access. The mandibular canal, mental foramen, position of the sinuses, and relative position of the apices are all factors in deciding whether to attempt surgery. I almost never perform surgery on second molars unless the tooth is strategic. Palatal surgery also can be quite challenging. Is it worth the effort? Only you can decide. Lastly, we must always ask ourselves, do we really want to do this procedure on this particular patient? Patients who have poor compliance, poor attitudes, unrealistic expectations, who are not willing to understand the risks and reduced prognosis that comes with retreatment are poor candidates for pushing the envelope. In that case, the extraction implant option may be better. Most talented endodontists can retreat a tooth either conventionally or surgically. All parties must understand that retreatment almost never has a better prognosis than when attempting initial treatment. I use the figure 20 to 30% reduction in prognosis when discussing retreatment, generally with patients, in comparison to me performing the initial treatment. The key is evaluating the patient. Are they a good candidate for us to try to save this tooth, or would extraction be a better alternative for this particular patient? These discussions should take place with the patient either prior to the referral or in conjunction with and in consultation with the referring dentist during presentation of the endodontist treatment plan. The popularity of implant replacement has greatly influenced the amount of endodontic retreatment that's being performed. For certain patients, such as those with heavy recurrent decay, replacement with titanium may offer a better alternative than trying to salvage a tooth the patient has difficulty maintaining in the past. Unfortunately, in the referral practice model, we rarely get to see patients over a long term, and we must rely heavily on the referring dentist's treatment plan decisions as to whether to attempt to retreat or extract. Implants are expensive where I live. Most insurance plans don't cover them. So for many patients, a $4,000 to $5,000 titanium alternative may not be possible. In that case, retreatment may be the only option that's covered other than extraction and fixed or removable prosthetic replacement, if that's part of their benefits at all. If we hope to perform treatment that will last, it's incumbent on all the clinicians involved to not only manage the case, but to consider the patient's needs and meet their expectations. There's no magic formula, template, or recipe. Each case is unique. It's up to us as clinicians to find a solution that is right for that patient. Remember, when we do the right thing, all of us get better. Patients and clinicians. Thank you for joining me, and I look forward to seeing you on our next trip when we go beyond the terminus.